Hello, I'm going to talk to you about caring for individuals with serious illness, substance use, and pain. This slideshow was used for an American Academy of Hospice and Palliative Medicine Grand Rounds that was held on May 16, 2024. I hope that you can reflect upon the feelings that arise when you think about caring for individuals that have serious illness, comorbid substance use, and pain. I'll outline some basic concepts of pain management that can be used for individuals with pain and risk for substance misuse. And finally, I'll talk about how we can incorporate our core palliative care skills that we already have into care for individuals with serious illness, comorbid substance use, and pain. I asked the people that I work with about why should we care about providing care to individuals with serious illness and substance use disorder. And here are some of their answers. Because it's the right thing to do. Because it affects people more than you may know. Because the downstream effects will be felt for years to come. Suffering appears in many pathways. Because they are just using coping skills that have been available to them and helpful to them in the past, such as the substances. Because they are reaching out for help and we can provide hope for them. It could be us or someone we love someday. Because this could be you. Because substance use disorder is a comorbid condition like anything else. Because we are all human beings. Our job is to treat pain and suffering safely for all those living with serious illness. This is just another medical condition that causes suffering for patients and their loved ones. Dignity, ethical. All people deserve comprehensive and compassionate care. We've come a long way in the palliative and hospice field. I did a quick literature search using substance use disorder or substance use or addiction and palliative or hospice. And you can see that between 2000 and 2010, I found 339 references, whereas between 2020 and present day 2024, when this is being recorded, there was more than 687. I remember one of the first individuals that I was involved with that had serious illness, substance use disorder, and pain was back in 2008 when I was working in home care, palliative care in New York City. And my colleague had a patient with pancreatic cancer who had comorbid substance use. No one would treat his pain, so he went from emergency room to emergency room. We crafted a plan for her to safely manage his pain at home while his disease progressed. We wrote up this case study and submitted it to nursing journals. It was rejected by 5 journals and finally got published, but the excuses were, this is not important, this person's going to die anyway, this is not an important issue. And even national academies in hospice and palliative medicine really did not pay as much attention to this issue until about 2018. And that's when we started to recognize that we in palliative medicine have an obligation, an imperative, to be able to treat people with substance use disorder to the best of our ability. Not all, but many can be treated within the palliative care realm. I'd like to introduce you to E. He's a current patient of mine that I met 2 years ago in 2022. He's a 54-year-old man with chronic obstructive pulmonary disease, bipolar disease, long history of substance use disorder with alcohol use starting when he was age 15, fentanyl use, and when I met him had active methamphetamine use, using up to 3 times a day. He was hospitalized due to severe pain, and it was found that he had a mass in his right upper lung and diagnosed as non-small cell lung cancer. Chemotherapy and radiation was recommended, and he had severe tumor-related pain, which was difficult to control, and still was using methamphetamine even during the hospitalization. Socially, he has what many of us have seen with adverse childhood events, with multiple family members having substance use disorders. He was disabled due to his bipolar disease. When I met him, he had unstable housing and was separated from his wife. Has an adult daughter, but both, when they found out about the cancer, were willing to help him manage his medications. He had multiple attempts over the years to treat his substance use disorder. Recently, when the pain got bad and before he knew he had the cancer, he tried to have the pain treated through going to the methadone maintenance at the opioid treatment program, but he was denied because of his continued methamphetamine use. So palliative care was consulted while in the hospital for symptom management and goals of care. So why us? Palliative care and substance use treatment have many overlapping core principles. We both believe in a holistic, comprehensive, and interdisciplinary plans of care. Both look at patients' goals, physical, functional, emotional, and spiritual. Both palliative and substance use disorder treatment look at the patient's psychologic and psychiatric comorbidities and also take into account the social and structural determinants of health, which may cause many challenges when trying to provide comprehensive care. In both arenas, we may encounter stigma, implicit bias, challenges in terms of immigration, abilities. All these things can be tied in. So while palliative care specialists are not obliged to become addiction medicine specialists, we already possess many of the core skills that will help us take care of people that have comorbid substance use disorder and serious illness. And we all care for individuals with substance use right now. Alcohol is one of the number one leading drugs that causes morbidity and mortality, with almost double the amount of annual deaths than opioids, and almost 5 million alcohol-related emergency room visits. So we have to think about the DSM-5 at the time of this slide was almost 30 million people, that were diagnosed with alcohol use disorder. So it is related to significant mortality. It's just that we may not notice it as much because it's something that develops over time. And we see people when they have end-stage liver disease or when they're hospitalized with complications secondary to the alcohol use, such as motor vehicle accidents. And tobacco-related mortality is one of the leading causes of death, with almost 500,000 people dying annually, including deaths that may happen from secondhand smoke. And so this is one of the leading preventable cause of death in the U.S. And many of us are taking care of people with chronic obstructive pulmonary disease and lung cancer that are a direct effect of their cigarette smoking. But we can't discount the challenges we've had because of the opioid crisis. This started back in the early 2000s when we had a change in attitudes about the way we prescribed opioids and began prescribing opioids much more freely for people with chronic persistent pain, not recognizing that a decade before we had an opioid crisis, thinking that these medications were somehow going to be safer. And we came to find out pretty quickly within 10 years that this was not the case. And what we started to see is that in 2010, there were a lot of regulations that came about, risk evaluation mitigation strategies for opioids, and clinicians started to pull back on their prescribing of opioids. And we started to see for the first time in decades a rise in heroin use. And then illicit fentanyl began entering the market about a decade or so ago, and maybe wasn't noticed as much at first because patients were telling us they were using heroin. But then when you were doing urine drug screens, you started to find out this isn't heroin, this is fentanyl. And now, overwhelmingly, as of 2024, it's fentanyl without stimulants that is causing the majority of deaths. However, there is more and more stimulant use, and we're seeing people with polypharmacy that are using fentanyl that may be laced with stimulants and xylazine that is causing the majority of the deaths. And what we see is that the criteria for different substance use disorders are similar, whether it's alcohol, opioids, tobacco, or others. The physical dependence would not necessarily be applicable if someone was utilizing an opioid as prescribed, but all substances of abuse have the same type of things with a compulsivity, a loss of control, use despite possible harm, with social, psychological, and physical consequences. And so they're all similar. And what we know now is that probably your biology and your genes accounts for about 50% of your risk to develop a substance use disorder. But we don't want to discount that your environment also plays a part. Chaotic home environment, childhood abuse, parents' use and attitudes, peer influences, community attitudes, they all play together. And most substances of misuse work and exert their influence in the ventral tegmentum, the nucleus accumbens, where we have the dopaminergic reward system. So this is the same system that when we eat a sugary donut or when we have a pleasurable sexual encounter, we have a rise in that dopaminergic activity, which makes us feel great. Now, if you have no risk for addiction, once that pleasure wears off, it's not like you're going to push back to try to have that again by getting another sugary donut. What we see, though, when people do have a risk for substance use disorder, there will be repeated efforts to utilize that substance again to try to get that same euphoria. And a lot of times they're chasing the euphoria that really never happens like it had the first time. And so many people that become addicted to substances will tell you that they didn't start using substances with an idea of getting addicted. They just loved the way it felt. And so they kept using it because of the way it made them feel. But over time, many are using the substance to just avoid the terrible withdrawal. There's a significant overlap between pain, mental health, and substance use disorder. We know that high-impact chronic pain affects more than 7% of the population, which means with the high impact that these people have increased disability that does not allow them to be productive members of society due to their chronic pain. And somewhere between 8 and 12% of people that take opioids from chronic pain develop an opioid use disorder. At the same time, up to 68% of people that are receiving treatment for their substance or opioid use disorder have chronic pain. And in the mix, we see that 50% of people with mental illness will experience a substance use disorder. And if you have chronic pain, up to 45% of people may have depression, PTSD, and 38% bipolar, 37% anxiety. Now remember, these are all estimates, but I think the most important thing to take away from this is that they're all linked. And so if we're treating someone who has mental health issues and chronic pain, we also have to think about, is this someone who may be at risk to develop a substance use disorder? So treating pain is a core specialty palliative care skill. And I know in our outpatient ambulatory palliative care clinic, it's probably one of the most common reasons that people with cancer are referred to the clinic. But treating pain is a balancing act. The first is just access to care. There are not enough palliative care specialists to actually be able to touch everyone with serious illness that may have pain. At the same time, you have many centers that have pain services that are interventional only and are not going to be able to be helpful in helping to craft a pharmacologic plan for pain. We have to think about being able to prescribe an effective treatment, you know, and keep the patient safe. The patient themselves may have a lot of fear about bias, and fear about stigma, especially if they have a serious illness and a history of substance use disorder. They may be less likely to report this if it's not already in the chart for fear that they will be judged. So we want to think about I'm hoping that I'm speaking to the choir and none of us use non-stigmatizing and uses stigmatizing language. One of the things I want to point out is that there's still the use of MAT, or medication assisted treatment, when we're talking about the use of opioid agonists for the treatment of opioid use disorder. This is your buprenorphine and your methadone. The preferred term is medications for opioid use disorder, because it's really not an assisted treatment, although those people that are in the camp that this should be abstinence only may feel so. But I think many of us who recognize this could be a chronic disease that maybe need treatment just the same way diabetes or hypertension does, realize this isn't an assisted treatment. It's a first line treatment for people with opioid use disorder, and trying to use return to use versus relapse, person in long-term recovery versus recovering addict. I mean, I think that if any of this language gets into the medical record, it follows that patient wherever they go. And just using stigmatizing language within a medical record can affect someone's care. When we think about treating pain, this slide is really based on the thought of treating chronic pain. But in essence, at least in our palliative care clinic, we are often seeing people earlier in the course of disease, and we know that many people are living longer with their cancer, and it's almost becoming a chronic disease for some type of cancers. When I think about people I'm taking care of with breast cancer that have significant pain from the cancer or its treatment, but they're now 20 years out from the initial diagnosis. We want to think about medications, of course, with opioids being one of part of a multimodal approach to pain. But we also want to think about, are we making sure that we help that person work with their mental health challenges? Are there any procedural things such as nerve blocks, stimulators, intrathecal pumps, acupuncture? And what about physical, like exercise? We know there was a recent study that was looking at, chemotherapy-induced peripheral neuropathic pain and the role of exercise as a possible way to improve quality of life for those with chemotherapy-induced peripheral neuropathic pain. So remember, when we're considering multimodal pain management, we want to reduce pain, restore function, improve quality of life, and cultivate well-being. If we're thinking about prescribing opioids, we want to consider doing an opioid risk assessment, just because it's good clinical practice. Are there a lot of studies that say, yes, this decreased diversion and misuse? Probably not. But I think as healthcare providers and clinicians that may prescribe, doing this risk assessment will give us an idea if we need to put safeguards in place. So it's not to deny treatment to people, but to make sure we have safeguards in place. And I would say this really should start in the acute care setting if opioids will be a plan of care after discharge. There's many tools available. You can click the link on the screening assessment tool chart from the National Institute of Drug Abuse. And we want to think about also incorporating universal prescribing for opioid prescribing into our practice. So universal precautions. For anyone listening to this recording that may have been practicing medicine or nursing in the 1980s, you know what universal precautions was, because it came about with the advent of AIDS. Prior to this time, we were probably not universally gloving when we were caring for patients, perhaps only in the operating room or when we were doing procedures where we may be exposed to blood or body fluids. But with the advent of HIV/AIDS, we didn't know who may be infected or not, and therefore universal precautions were applied. The same thing should be applied when we think about prescribing opioids, especially if we're not prescribing just at end of life for someone who's come into our hospital is going to die there, but I'm talking about when you may be prescribing over time. And this begins with a comprehensive pain assessment, a risk assessment on opioids, clear documentation reassessment, use of urine drug screening, and informed consent and a treatment agreement. I'm not using the word contract because it isn't a contract. As far as I know, we are not suing the patient. This patient's not suing us if we break the opioid treatment agreement. After Gourlay and Haidt, who first came out with this model in about 2005, it's evolved to include using the prescription drug monitoring program checks, prescribing naloxone for overdose prevention, and obviously coordination with colleagues. But I also want to introduce you to another tool, which is the 7 Ps for opioid prescribing, developed by Dr. Janet Ho out at the University of California in San Francisco. And this was used with her permission. And you can see the reference there where you can see the whole tool. And it's really looking at how do we balance opioid benefits and harms. First of all, like, what is the pain? Are we having pain that's going to be long-standing and ongoing? Or does someone like E all of a sudden develop a spinal cord compression and need neuropathic medications, need steroids, need possible surgery? What is the prognosis? We may be very different in terms of how we prescribe if that person's prognosis is days to weeks versus months to years. So patients that are on, say, methadone for medications for opioid use disorder, we should not usually take over that in palliative care. But say that person comes on to hospice and they have that severe pain and can no longer go to that opioid treatment program daily, this may be a time that we take over methadone prescribing, because in this case, it would be for their cancer-related pain. What's happening in terms of that person's performance status? We may have much less concerns about the way we prescribe if the performance status of that person has rendered them chair or bed bound, and therefore maybe less risk of misuse or illicit use. What happens in terms of the psychosocial factors? Now, is there persons, people, institutions in place that are protective? Like in the case of E, he has a wife and a daughter willing to help and willing to administer medications. This is very different than if you have someone who's unhoused without any psychosocial support, or if the person that is their psychosocial support is also actively using. What kind of partnerships are there? Is this person involved with oncology or cardiology, with addiction medicine? All of those things would play in, to, how we balance the risks versus the benefits. And also parity. So we would have to ask ourselves, would the treatment recommendation differ if that patient did not use substances? Now, it may differ depending on the risk for harm, but we have to think about that when we move forward. Are we being stigmatizing versus just being safe and utilizing the best harm reduction approach? This is an example of an opioid management workflow that was developed by the Oregon Pain Guidance Opioid Prescribing Guidelines Group, and the slide was adapted and used with permission by a pain anesthesiologist, Dr. Seddon Savage, that I've worked with at Dartmouth. It begins with a lot of the things that we saw with our universal precautions for opioid prescribing, which means a comprehensive pain assessment, discussing the goals of treatment. Again, may be very different if we're working with someone who has a cancer that's possibly curable versus someone who may be in the last weeks to months of life. Initiating a trial, again, co-prescribing nasal naloxone. If we inherit a patient that's already on opioid therapy, we may end up discussing plans for rotation, tapering, or possible discontinuation. I remember about 4 years ago, I inherited a patient who has severe chemotherapy-induced peripheral neuropathic pain. Her last treatment for breast cancer was in 2005. but she's had this debilitating pain and was on up to 80 milligrams of methadone daily before I met her, and had been weaned down to 40 milligrams daily in divided doses. Over the last 4 years, we've been able to slowly wean and now have her on 15 milligrams daily. She did not tolerate a rotation to buprenorphine, so I realized we've reached a point that no further tapering may be possible. But if someone has no progress to their goals and has unmanageable side effect or persistent risk behavior, we may have to consider taper or transition to medications for opioid use disorder if they're not already on them. If someone who has a chemotherapy-induced peripheral neuropathic pain or pain secondary to the treatment for cancer with no evidence of disease, we may still continue to intermittently try to taper, but if there's no signs of aberrant behavior and the functional status it remains good, or as good as can be expected, we may then continue opioids. In our own clinic at Dartmouth-Hitchcock, we incorporated this opioid prescribing guidelines into practice back in 2017-18. And this was a little quick serve chart that we use also when we are teaching our fellows who all participate in a half-day weekly continuity clinic. Again, it starts with what do we do within the first 3 visits, which looks at, opioid risk screening, calculating and documenting our morphine equivalent daily dose, completing a treatment agreement, and urine drug screening. But at every visit, we look at the prescription drug monitoring program review and calculate and document the morphine equivalent daily dose. How we see them in terms of how often we see them, how often we do urine drug screening, how often we may do pill counts, is based on their level of severity. You'll see the scores here with an opioid risk tool of less than 4, 4 to 7, or greater than 8. This is based on the original opioid risk tool developed by Webster and Webster in 2005. I recommend the revised one by Cheadle et al. In 2019, which really goes to a 0 to 3 scale, and people are either high or low on it. It's much more specific and sensitive for the development of potential opioid-related disorders. And this is just one way that we try to manage our pain in patients who are on opioids. It changed quite a bit, obviously, when COVID hit, and a lot of our visits are now telehealth, but we've kind of indicated based on the states that we practice in how often that person has to come in for an in-person visit. In these next couple slides, I'm going to talk about some ideas for pain management, most specifically buprenorphine, because I think this should be considered as one of our first-line analgesics. The Veterans Administration 2022 use of opioids for chronic pain guidelines says if we need to use opioids for chronic pain, buprenorphine should be considered. The same way with the United States Department of Health and Human Services 2019 multimodal guidelines. The CDC guidelines excludes people with cancer that are on palliative care, but I think we need to look further than this now, because more and more of us are seeing patients that have no evidence of disease but still have pain secondary to their disease process and still require chronic opioid therapy. So why am I such a big proponent of buprenorphine? So buprenorphine has a lot of unique properties. It is labeled a partial mu agonist, but it's still a potent analgesic, but its partial agonism means that there is a ceiling on respiratory depression, and also because most of its mechanism of action is in the spinothalamic tract versus the nucleus accumbens, there is less chance for euphoria, which means a limited potential for addiction and tolerance. There is because of the kappa antagonism, there may be like reduced depression or dysphoria, and there have been some studies that have been ongoing on the use of buprenorphine for refractory depression. But I think most importantly is that people are not getting that reinforcement in the dopaminergic reward center that they would get from some of the full mu agonist opioids. Buprenorphine, though, has very little gastrointestinal bioavailability, and it has to be administered intravenously, buccally, sublingually, or transdermally. We can use it in people with renal failure and mild to moderate liver failure. While there are some drug-drug interactions due to the CYP450 system, much less than what we see with methadone. And while buprenorphine can cause QTc prolongation on EKGs, it's not been associated with the development of torsades de pointes. And so I know in my own practice, I'm not routinely looking at EKGs like I would do if the person was on methadone. So buprenorphine has a strong affinity for the mu receptor. And so this is where, when we think about using buprenorphine for the treatment of opioid use disorder, it latches onto that mu opioid receptor very strongly. So if someone uses an illicit substance, there's less risk for overdose. And at the same time, it may help to curb some cravings because this substance of illicit use is not attaching to the mu opioid receptor. But just because it's attached to the opioid receptor doesn't mean it activates it. Theoretically, we have thought that it blocks other opioids from binding to the receptor, but in practice, we're seeing very differently. So, for example, if someone comes into the hospital for an acute pain crisis or for surgery and is on buprenorphine, we can still treat over that using higher doses of intravenous hydromorphone or fentanyl, and there is still enough mu opioid receptors available, even when that buprenorphine is at 24 milligrams daily, to actually help treat the pain. And in my own hospice practices, I have people that have been maintained on buprenorphine, and I am using hydromorphone, for example, for breakthrough pain secondary to their advancing cancer. But I'm keeping them on the buprenorphine because I feel that it is protective in the event they had recurrence of use with illicit fentanyl. There is some evidence that it may prevent that person from having a overdose and death. There's a lot of controversy as to whether the analgesic ceiling is there for higher doses of buprenorphine. Part of this is because it's only been FDA approved at 24 milligrams daily for the treatment of opioid use disorder, and that the higher dose buprenorphine products have never been FDA approved for pain. Not because they're not a potent analgesic, but this is part of our structural racism, structural bias that we have in our systems related to the treatment of opioid use disorder, because there's no reason that this should not be FDA approved for pain. What happens, however, when someone comes in the medical center and say we took them off of buprenorphine and we started treating with full mu agonist opioids such as hydromorphone or fentanyl, we may need to use higher doses in the first day or two because that person still has a lot of buprenorphine on their mu opioid receptor. But after about 72 hours, when the buprenorphine disassociates from the mu opioid receptor, we may find that the doses of fentanyl and hydromorphone that we utilized on day 1, 2 are too high and could put that person at more risk for opioid-induced respiratory depression. On the other side of it, if someone is on a full mu agonist opioid and has been getting that routinely, and we decide to start buprenorphine, in the traditional initiation of buprenorphine, that person would have to be in mild to moderate opioid withdrawal. Otherwise, if you put the traditional use of buprenorphine at the recommended doses, you could precipitate an opioid withdrawal. And that's why there are many methods that are discussed about using low dose initiation of buprenorphine for people already on opioids. And that's well beyond the scope of this talk, but there are many talks available and articles available about this use. This is a chart of the buprenorphine formulations. So what you will see in the top of the chart, you will see the transdermal patch, a transmucosal film, and intravenous or intramuscular formulations. These are FDA approved for pain. And the beauty of the transdermal patch and the transmucosal film is that you can use this in patients that are opioid naive. So if you have someone who's not been on any opioids at all, you could start a low dose transdermal patch at 5 micrograms an hour or a low dose transmucosal film at 75 micrograms every 12 hours in someone who is opioid naive. And this is perfect when you think about someone that may need, for example, 2 or 3 doses of morphine or hydrocodone daily, or have been only on 1 or 2 doses but is having of an opioid daily, but is having around the clock pain. These formulations would not be helpful if someone is on more than 160 milligrams of morphine equivalent daily. Now, the moderate and high dose buprenorphine products include a sublingual product that is combined with naloxone or a mono product, and 2 subcutaneous injections. In terms of the sublingual products, the one that's combined with naloxone was combined with naloxone with the idea if someone tampered with that medication and injected the buprenorphine, the naloxone would block the pain and the euphoric effects. The mono product of just buprenorphine alone was generally reserved for people that were pregnant because we didn't know the effect of naloxone on the fetus, or people that were in liver failure or have a naloxone allergy. In my own clinical practice, when I'm using the higher dose buprenorphines for pain, I will sometimes use the mono product, because it's a lot less expensive. And if someone does not have good insurance coverage with certain coupons, I can get a 90-day supply, a 30-day supply of 98 milligrams films for less than $100. The subcutaneous formulations, the weekly and monthly, as of this recording, have not been studied for pain. So in this little chart, you can see who may benefit from buprenorphine. So someone who's opioid naive, as I said, could both use the transdermal or the buccal. Someone who can't take oral extended opioids, again, could use all 3 formulations. The sublingual here means the higher dose buprenorphine that's FDA approved for opioid use disorder and used off-label for pain. Someone was same way with cancer remission, at risk for misuse or current substance use disorder, you would never use the transdermal or the low-dose buccal to treat the substance use disorder. But if someone did not require more than 160 milligrams of oral morphine equivalents daily and was at risk for substance use disorder, or say using something like methamphetamine but not opioids, this is where you might use the lower dose patch or the buccal formulation. Again, this lecture is not intended for you to know how to use buprenorphine if you haven't, but you can seek guidance from colleagues because there's many that are available. The American Academy of Hospice Palliative Medicine has learning activities. The Providers for Clinical Support Systems for Medications for Opioid Use Disorder, the PCSS-MOUD, is a great organization that offers weekly free seminar lectures, has a great archive of lectures, offers 8-hour live or webinar courses on prescribing buprenorphine, and if it's still available, I know that when I started in 2018, I had a mentor that I could speak to when I needed help with prescribing buprenorphine in those early days, because I helped start the use of medications for opioid use disorder within our palliative care clinic. Once, as a nurse practitioner, I was able to prescribe buprenorphine for opioid use disorder. Now, this doesn't mean that you would not use full mu agonist opioids, but you have to be careful when there's active substance use, misuse, or risk for recurrence. And again, you would go back to that 7Ps chart, weigh the risks versus the benefits. So it would depend on the stage of the disease, the support system, staff availability for frequent follow-up. I had a patient at one point that I was prescribing fentanyl patches and morphine for breakthrough pain and was prescribing every 3 days. Many clinics would not have the sustainability and the staff available to do that. Obviously, if you're in an area that addiction medicine is available, you would love to collaborate with them, especially if you have someone with severe substance use disorder or active substance use. And you want to consider, using a limited supply of opioids. Like for some of the patients, when I'm first actually working with them, I might just prescribe weekly. Minimize use of opioids that are reinforcing. There's not a lot of studies about this, but we know probably the more lipophilic the opioid is, the more risk for activating that dopaminergic reward system in the nucleus accumbens. So, for example, oxycodone may be much more reinforcing than morphine, and there's been some studies to show that. Very few, though. You want to make sure you prescribe naloxone for opioid reversal, and you don't want to discharge or abandon the patient. But you may need to change plans, and you may reach a point that even prescribing something like buprenorphine is no longer safe, especially if there is diversion. Finally, I'll say that we should be prescribing naloxone for all patients unless they are at end of life or imminent death. And I know at one point I was challenged by a colleague who asked, how often does this occur in people on opioid therapy in palliative care in terms of opioid-induced respiratory depression? The number can be quite small. We don't have an exact one, but I look at it this way. If someone has an allergy to bees, would you say, well, I am not going to prescribe epinephrine because there's no bees in my area? No, you would not do that, because good clinical practice, that person would have epinephrine if needed. So anyone who's diagnosed with a substance use or opioid use disorder with active use, or even if they're on medications for opioid use disorder, or especially if they're in remission and they're not on medications for opioid use disorder, should be prescribed that. Anyone who's on greater than 50 milligrams of morphine equivalent daily, this is what the CDC guideline says. In our own clinic practice, we say 50 milligrams, but I tend to err on the side of prescribing for almost everyone who's on opioid therapy, especially if they're frail, have organ dysfunction, which many of my patients do, or have safety risks at home. And safety risk means anyone else in that household, whether it's children, grandchildren, adult children. And I've had people who have thanked me for actually prescribing it because they feel safer having it at home. And one actually talked about using it with a neighbor to prevent an overdose. So let's go back to E. In July of 2022, we started him on buprenorphine at 8 milligrams sublingual every 8 hours, along with adjuvant therapies such as medications for neuropathic pain and inflammation. He later told me he thought that I was full of when I was prescribing the buprenorphine because he didn't think it would work for pain. He actually ended up with a respiratory depression, unclear whether it was, but he ended up on ventilatory support in August of 2002 for 2 weeks. But recovered from that in September of 2022, he started chemoimmunotherapy, and in March of 2023, he completed chemoirradiation. And as of this date, which is May of 2024, he remains on surveillance with no evidence of disease recurrence. He's been pretty stable on his buprenorphine. Most recently, in May of 2022, he wanted to stop it, thinking it wasn't working anymore, and had started drinking alcohol again. But we talked about, the risks, and as far as I know, he's back on it. But again, not punishing for not staying on it, not punishing because he started drinking again. He's so proud of the fact that it's been almost 2 years and he has not used methamphetamine. He now has his own apartment. Remember, he was unhoused. He's reconciled with his wife, who provides daily support and actually still gives him the medications. And he's involved with his daughter and his grandchildren. So we actually can make a difference for those people who have opioid use disorder or substance use disorder. And I'd like to leave you with talking about my patient B. The slide's not there, but B was a man who had pulmonary artery hypertension. He was 43 years old, married, 3 children at home. His mother had died of the same disease at age 42. He had started treatment for his peripheral arterial hypertension. He has severe diabetic peripheral neuropathic pain. He came to me, the referral was because he was going to discontinue treatment because the pain that he had experienced from his diabetic peripheral neuropathic pain and the treatment side effects for the intravenous treatment for his pulmonary artery hypertension were so severe that he had been in bed for 1.5 years in excruciating pain. And every clinician that he saw prior to coming to me had treated him with at most 30 hydrocodone a month. He died just short of his birthday in December, leaving a wife and 3 children ages 8 to 16 at home. His wife wrote me a letter after he died, and I'm going to read that because I want you to think about how what we do when we treat our patients can affect people even after their death. Now, B had no substance use disorder, but he might have fit the profile. He was in his early 40s, tatted up, lower socioeconomic status, might have fit the profile, had family members with substance use disorder. So she writes, "Dear Kathleen, I just wanted to drop a line and tell you how grateful I am to you and the work you do. I think it's important to tell you how much you made a difference in B's life. As we have told you before, without his medicine, B was in bed for 1.5 years, just existing in excruciating pain, 24/7, 365. And every doctor before you brushed him off and treated him less than because he did not want to be in constant pain. Please know that because of you and the treatment you prescribed, we were able to have his last 2 years be more than existing. He was living, and we made so many more memories. I'm forever indebted to you for giving me my love back, for giving him the ability to make memories with his family. Thank you for listening and not treating B like some drug addict, seeking a fix, but instead like a human being needing help with pain management and mental health help due to his incurable disease. Thank you for giving our children the ability to make memories with their dad, as memories are all we have left now." So I want you to take away that we have to consider the cultural and implicit bias that may impact someone's treatment and have ripple effects on their families and communities. And that we as palliative and hospice clinicians have the core skills to work with and improve the quality of life with individuals with serious illness and substance use disorder. And through a systematic approach, we can treat pain in individuals with substance use disorder and serious illness. And finally, that buprenorphine is not the only tool in a clinician's toolkit, but should be part of a clinician's toolkit for the treatment of pain and, when applicable, substance use disorder. There are some recommended resources. The Boston University has a free curriculum on the safer, competent opioid prescribing. It's called Scope of Pain. As I mentioned earlier, the Providers Clinical Support Systems for Medications for Opioid Use Disorder is a great resource. And I've included the Pain Management Best Practices Interagency Task Force report with recommendations. There are some selected references on the next couple slides. Many are related to the use of buprenorphine. And finally, I want to say that if you have questions, you can feel free to reach out to me. My email is here, my cell phone is here. I'm more than happy to help you on your endeavor to treat pain, serious illness, and substance use disorder. Thank you for your attention.